strategies, and then spend a little time talking about planning for activities going forward. And then at the end, our evaluation team wants to talk a little bit about the plan for evaluation and how that's going to work. Is there anything else that should be on this agenda, or any concerns about any of those items and whether they're in the right order? And okay, anybody on Zoom? I need to remember to look over here at the screen. Okay, well, I don't want to call on people, but I really hope everyone has a chance to participate. And if any individual is going on too long, I may cut you off. But who wants to start? What are you working on?
This
You
is
could do it
DL
by
Wyoming.
state, or okay, go ahead. And who's speaking?
Hi, this is DL in Wyoming,
Uh-huh.
and we, like many others, we are working on older adult falls, and we're trying to perpetuate the Tai Chi movement for better balance throughout Wyoming. And we're also working with public health nursing and our Safe Kids partners to distribute helmets to community members who may not be able to afford helmets. We're working with our highway safety partners on motor vehicle crash reduction. And I'm specifically partnering with the Wyoming Highway Patrol to do some training with law enforcement on how to keep older adult drivers safe.
Great. And what are the challenges you're facing these days?
Well, I think the challenges that most of us face, and I particularly face, is just having enough money to do everything that we want to do, and then having the people available, the expertise, the subject matter expertise to come into Wyoming to help with education or finding resources. So those are some of the bigger challenges that we face. And I am a program of one right now, and that's another challenge.
Yeah, so it sounds like as a program of one, it sounds like this network could potentially be particularly helpful. So at least you have people to talk to who are like-minded.
And DL, you're in the Department of Public Health?
Department of Health in the Public Health Division.
Okay, thank you.
And speaking of Wyoming, just reminds me of one thing, but it could apply to a number of the other states, and that is I work with another program that is the injury prevention group from the Indian Health Service. And there has been encouragement, I know, from CDC as well as from the Indian Health Service for those folks to join these networks. And I know Wyoming has several tribes that are funded to do injury prevention work under that initiative. And I don't know, DL, do you work with any tribes at this point?
We have two nations here on a shared reservation, the Northern Arapaho and the Eastern Shoshone. The Northern Arapaho, I have really great partnerships with. I'm still working on partnerships with the Eastern Shoshone. They recently have separated their business council, so they're operating as two separate nations on the reservation, and that has provided some complications. It's my understanding there's very limited injury prevention work being done, and the Eastern Shoshone partner with the Wyoming, Montana Indian Health Services to deliver some injury prevention programming, but it's not very broad or depth or have any depth to it right now.
Yeah, and I know, and I don't want to stick on this point, but I do know that that there's an Indian Health Service tribal epidemiology center in Billings, Montana that works with a number of the tribes. I don't know if they reach into Wyoming or not, but they
do.
They
do.
work with
part of their scope is with the at least with the Eastern Shoshone. I don't know if they've maintained the partnerships with Northern Arapaho.
Okay, yeah, and so they are funded to provide technical assistance to the tribes in that region, and just might be a good group to connect with at some point. And I think one thing that Georgie and I have talked about is trying to find ways to get those folks more involved in this network for the sharing that can go on within states where there are both public U.S. Public Health Service and public health departments as well as tribal departments. I didn't say that very well, but you know what I mean. Okay. How do you want to do this? Do you want to offer feedback to people as we go along on the challenges that are raised? Does anybody have any suggestions? I mean, her challenge is being a program of one and not having enough money. Anybody got ideas?
I'll speak about the CDCs. So I don't know if many of you have applied for the Public Health Associate Program. Are you aware of the Public Health Associate Program?
Yeah, we've had a couple of PHAPs here in Wyoming.
Oh, great. And so there have been some modifications to it, but it is, especially for those programs that are Program of 1 or Program of 2, the Public Health Associate Program is a paid 2-year program where we send out a PHAP. They usually have either a bachelor's or master's degree. They are totally funded by the CDC, and the main components for the application are mentorship, and that's a huge part that we've seen. We actually have a very high, how do I say this, failure rate for injury prevention programs. And part of the issue is when we're writing those applications, and we've tried to do a little technical assistance, we're going to be doing some more this September, is that we really need you to focus on 1 or 2 topics. So I know that we cover a variety of things, but for the PHAP program, they're really wanting those associates to get 2 years of solid experience, because then it helps them able to apply for government positions within the center or within the agency. And part of that is being able to say they have 2 years of experience in a particular subject. And so we want to strongly encourage all of our state partners, particularly our injury and core, because we do know that these are small staffs and you have limited resources, because it is a paid person. And we've had associates running whole parts of programs. And I know for those of you who've had, maybe you can speak to some of the work that your PHAPs have done. And so, but a key component of that application is having an experienced staff member serving as a mentor with both what we call classroom types of exercises for that associate, because it is a training position, but also having experiential where they're both a member of a team on something, but also leading an activity. And so we can definitely talk if you're interested in those. I'm the PHAP representative for the center, and I'm glad to provide technical assistance for your applications as you're getting ready. They're always due in January, and it's a super short window. It's literally a week and a half. I've tried to get them expanded, but they won't. And so, but the applications are start being available. You can start. We have 3 training videos and 3 training exercises, and we've had states that get a PHAP every year, and we've had cities that are Richmond. That comes to mind. They have now a PHAP peer mentoring within it, so they're a super strong group, and so they get a PHAP every cycle, and it's a 2-year paid, and you provide the training, but then they are also there, and many people hire those PHAPs afterwards.
So when you say failure rate, you mean like the sites aren't getting placed with PHAPs?
Our applications from injury are not making it to. So we have
Even
a 2
matching
they're not
process?
making it past the objective review.
Oh, okay.
And so the way it works is the objective review is conducted by the PHAP program, and then they're sent out to the centers, and they're ranked based on the strength of the applications, and then those are sent back out. And so it's gotten more competitive. However, we do know that our numbers are much, in terms of our failure rate, it's around, last year it was 60% of our applications didn't get past objective review. And part of it was because when we write our injury activities, they were doing motor vehicle, child abuse and maltreatment, substance abuse, and that's just not something that is going to get past the objective review.
Because it was like too
many broad. It has to be a subject.
Yeah.
So because when they apply for under USA Jobs, they have to be able to have 2 years of experience in a topic.
So like an opioid focus.
Yes. So the opioid ones made it through.
Okay, so how does that that seems like in conflict with the shared risk and protected factor approach.
Yes.
And how as potential applicants can we like frame that the importance of shared risk and protective factors covering multiple topic areas, yet still be focused enough to be successful in PAS? Or should we just not go there?
So I can give you the politically correct answer. I tell you the nuts and bolts. You have to choose a topic.
Okay.
We have tried to get them to understand that we are doing a shared risk and protective factors. We sent them our FOA. We've explained. I'm on the monthly calls, but that's not translating to when they do the objective review, because the objective reviews, they pull people from everywhere to do them, and then they still have that guidance. And so it's still, we still saw that last year with that high failure rate. And so what you could do, we did have a few that did, they focused on children. So they did child abuse and neglect, and they covered a realm within there, but even that it was only like 2 topics within that. So it's still very important that you stick to a topic.
Did you pick a risk factor or a protective factor?
Yeah.
Well,
But
I get it.
if it's so because you're up against, I know it sounds weird, but you're also up against like HIV or what else do we have at CDC? All of chronic, like hepatitis. So we have people working a particular subject, and so it has to be a subject when you're writing your
And
application.
it's about making them marketable afterwards.
Right.
So what kind of, I mean, and I don't see that it could be seen as being rigid of having just one subject, but I think that's where the mentors and the agencies, it's up to them. And so I know that I'm assuming one of the people we worked with, and I'm trying to remember, Megan Waters. Yeah, she's worked, but I've worked with her on a number of different
changed.
we hired her. Right, but I mean, but the thing is that I can remember, even though I worked with her, that the point of her subject matter was focusing, was it the opioids with hers, but part of her role was to work with different agencies. So she worked with the University of Utah. She worked with the Department of Human Services. She worked with the VA and the Poison Control Center. And so I think that's part of when we're talking about the shared risk factors, is that while we have one subject matter, it's that collaboration coming together and seeing that, yes, while the health department focuses on this component of opioid overdose, and I focus on it slightly different, there's still something in the middle that we share, and we look at the factors that we have combined, and then we can address it. So
yeah, I mean, the associate might actually, that might be the thing they do, is to look for the cross-system connections. I mean, when we went around and introduced ourselves, we all talked about what our specialty was, and here we are at a shared risk.
and Megan's great, by the way.
Yeah. Oh, yeah.
I wonder.
She's a sexual assault now, though.
Well, she did all that research she did all the stuff with the naloxone too. Is that part of her too?
Well, early on, Angela. Now it's Angela that does the naloxone stuff.
All the research, because I know that. Sorry.
It's okay. Yeah.
I'm wondering, in the interest of moving on to make sure we get to everyone, I'm wondering if we should table this, but I'm thinking that it sounds like there may be enough interest in this application process that maybe it could be an agenda item for a future
And maybe
one
if
of
you
our
have-
meetings.
If you have some background
Before
information,
January.
you could send us to the-
Oh, yeah, I have all
I was also
Yeah.
thinking, like, as states, we could support each other in those applications. So if just to strengthen them, and so that we could be, as states, be more successful.
I'm sorry. Well, I have to check again. I 1 year asked a state if that was allowed to share. I haven't asked them this year, so I'll ask them again. Tennessee has been super successful in getting PHEP every year. So
Is there an existing roster of qualified associates or is the state recommending someone? How does that?
no, there's a separate applicant pool and that is super competitive now. It's because it's a 2-year. And with the cuts and freezes that are going on, this is a way to get into a state health department for 2 years and kind of get your experience before.
So they apply for the program, and then the states apply.
And then we match.
And say,
Like
so
EIS.
Yes.
I'm not with the health department,
It also called.
but the SAMHSA, we actually, our Amy Franston was one of the successful fellows from SAMHSA. And we did the same thing, and I was when you said, I'm like, oh yeah.
Yeah, and we've tried to pass the PCAP when the announcement comes out to all of our partners, because we want, I mean, that's what they're there for, is to help when they're, especially with capacity, when there's.
The other thing, by the way, is we know other rural areas, I don't know if it works for a state, but they use AmeriCorps.
Uh-huh.
Oh, like this.
Yeah, so like
So,
Tiffany uses AmeriCorps.
Yeah.
so in an effort to move on, I mean, what I'm hearing though is I mean, tell me, and those of you online speak up as well. I mean, I'm hearing interest in pursuing this line of discussion about the PHAP and perhaps AmeriCorps and other kinds of opportunities to find staff. And so maybe, Georgie, that's a topic to put on the agenda for a future
CSTE.
one of these meetings. Shall we go on to another state that would like to talk about what they're doing and challenges they are having, and maybe get some help from their colleagues? Who wants to go next?
This is Jeremy from Montana.
Uh-huh.
And so some of our recent successes are what we're excited about. We've been working a lot on the DDPI grant through CDC for opioid overdose prevention. And just recently this week, we've had a meeting with our prescription drug registry representative from the Board of Pharmacy. And we've been trying to build our relationship with them over the past year, and we've been having some difficulties through laws and statutes getting access to the prescription drug registry data. But at our last meeting, we did bring in our public health lawyer with us to kind of examine the current laws, and he is thinking that we do have authority through the law to obtain data. We're still working out the details on if we're going to be able to have identified data or de-identified data. But prescription drug registry is now making it a priority to get us access to that data. That's been kind of success and encouraging that they're more willing now to work with us and get us that data. Some of the challenges that they're still having with that is currently our drug registry is kind of a homegrown system right now, and they're about to go through an RFP process to put out a bid, and are considering changing their system to the system that most of the states around the country have been using, which could bring benefits and challenges. It might push back the date we're able to get de-identified data if there is a big system change. But we are looking at seeing if we can get an agreement in place to have that identified data. So that's been an encouraging thing. And another aspect of that grant, we've been working with our substance abuse prevention programs over at our addictive and mental disorder division, and they received their STR grant through SAMHSA. So we're coordinating our efforts with them to help get naloxone out to first responders. So this past legislative session, there was a law passed to allow first responders to carry naloxone with them. So we're going to be working with the STR grant to develop some trainings and get out and provide trainings to first responders, EMS, police, fire departments, and school nurses. And our partners over at AMDD are going to be supplying naloxone for first responders to kind of remove some of those barriers of the smaller rural services that don't have a lot of funding. We have a lot of volunteer EMS around the state. So we would like to kind of help out with the training. They're helping out with supplying naloxone, and then we'll work with hospitals for sustainability of resupplying that naloxone. And we're really hopeful that that will bring down the deaths around the state. So those are two of the areas in the opioid grant. Also, we've been working with the University of Montana on applying for fall prevention funding through the ACL grant opportunity. So we're waiting to hear back on that. Within our department, we do the Stepping On fall prevention program, and we're continuing with that. But if we do receive the ACL funding, we're hoping to expand to have a Matter of Balance program, a Tai Chi program, expand Otago physical therapy fall prevention program. So that's another area there. Another challenge we've had working on motor vehicle injuries. Our state currently does not have a primary seatbelt law, so that's been one of our main focuses for the past several years, is trying to get primary seatbelt legislation passed. That wasn't successful again this year in legislation, so our Department of Transportation has been regrouping strategies on other, we'll continue pushing for positive policies like that, but looking at other ways to reduce our motor vehicle deaths in the state, because Montana's got a very bad death rate on motor vehicle injuries. Some of our challenges there.
I know that's one that the tribes that I've interacted with in Montana are very concerned about as well.
Yeah, and we do have several tribal representatives that work with us in our motor vehicle injury areas. Also, back on opioids too, we are working with several tribes and American Indian representatives from urban centers on efforts on the opioid overdose as well. And yeah, we have made some connections with the Billings area IHS and the Rocky Mountain Tribal Epidemiology Center as well.
So anybody in the group want to offer up any assistance or advice on any of those challenges? I didn't mean to cut you off if you weren't done.
No, I think that's a good point to stop.
This is Benny, and I'm not necessarily offering on challenges, but I wanted to say that in Iowa, we also are using for falls prevention, manner balance, stepping on, Tai Chi for arthritis, and are introducing Otago. And we've had the benefit through our Department on Aging to have the ACL grant in 2 prior years, and we have it now. So I would love to share any ideas and also just learn from everybody else about how you are sustaining these programs. But anyway, I'll say more when we talk, but I just want to capitalize on that, Jeremy. I think that's great work you're doing.
Yeah, we definitely like to reach out and kind of collaborate or compare ways on we can improve our fall prevention efforts around the state.
Jerry, this is Lindsay from Colorado. We have the same challenges with regard to primary seatbelt legislation here, and have been borrowing heavily from Utah and their success. And so they were willing to share stuff with us, which has been helpful. So hopefully they would share with you too. But we've been trying to repackage messaging and creating kind of reframing the arguments for primary seatbelts. And so we have a group that is meeting. We ultimately, all the parties involved decided not to push for primary seatbelt legislation this year for a variety of reasons, but are really trying to work on, how do we talk about this differently? And Utah did such a great job of, kind of reframing the argument and pulling in some partners from the business community and other players that I think really were likely the reason why it passed in Utah. And I think our states face sort of similar challenges in the legislature with regard to that. And so we would certainly be happy to share some of the materials we've developed, and if Utah is willing, we really
Feel
benefited.
Free to go ahead and share, right?
Okay, I will share it. I have a whole folder called Utah, so I'm happy to pass that along. And we had the kind of lobbyists for the Department of Transportation in Utah come out and speak to our groups and our Department of Transportation people, because they're likely to be the ones that will lead the charge. But it was, we've been kind of inching along with trying to even get our health department support and really to see it as a public health issue. And so a lot of our, language around it is sort of geared that way, because, the straight up safety messages haven't worked the 8 times we have done it. So.
And there was many years of failures. I mean, I've been a health department almost 15 years, and they've been trying to do primary seatbelts since then. And even when they did pass it, it had a sunset. So it went into effect, and then it had a sunset, which would have been next year. But then we got some legislation passed. This past year.
I actually wondered about that.
That took the sunset away. So it's now, unless something else happens, it's law.
You're mentioning that the public safety message doesn't always carry. If you can find even one supportive legislator on both sides of the aisle and get them to work through the National Conference of State Legislatures, they can bring in, the NCSL will organize a legislative briefing where they bring in legislators from other states that have passed the primary seatbelt law and can talk about it from an economic standpoint, from a sort of cost benefit standpoint. That usually carries a little more weight in the among the legislative audience.
And I wonder too, I mean, is CDC able to provide guidance or connection to states that have gone through this process in recent years? Maybe. I think it's Utah.
Yes.
Or is it just
Utah?
do this?
Yeah.
I mean, for
And
us.
Kansas probably right before that. Yeah.
Yeah. Mhm.
I mean, it is our
Yeah, I mean, I don't-
region that's the last
That's-
to adopt.
Right.
So.
Which is weird because you all have. I was
Except
like,
for
I
New
didn't
Hampshire.
even know that you all didn't have. You have snow. How do you not have primary seatbelt laws? I did not.
Well, a lot of
That's
people,
Midwestern.
I mean, and a lot of people don't know. Like if you ask the general public.
Yeah, my husband's in Colorado. He didn't know.
Yeah.
I
was like, what?
I didn't know you didn't have
Which kind of works against you. If, what you're hearing is, oh yeah, we already have that law,
Yeah,
then
right.
convincing people that passing primary legislation would actually do anything to
Yeah.
your seatbelt use rates or fatalities is a harder argument. So that's some of the discussions we've had. We even did an opinion poll, like an actual Wayman digit dialing opinion poll that CDOT funded, and they, there was really high support from constituents. They're like, yeah, that sounds good. Like, I would vote for that. So, we were considering as a group, maybe we need to nudge some folks to do a ballot initiative versus the legislative route, because we have some stubborn legislators that, despite learning from other people, think we do what I want and
Well, some of the messaging is conflicting also, right? There's like the click it or ticket messaging, or whatever our messages in Colorado.
and it's
like,
it's hilarious. It was the same way in Utah. They did this huge campaign like,
right. And we
this does
don't even
not
have the
mean
law.
anything
Right.
here.
Okay, so it sounds like some information exchange that's going to take place on that one.
Yeah, for that feedback. And yeah, we have had a representative from Utah come and speak at our Department of Transportation meetings, and they had some great ideas on bringing in other groups such as pilots and UPS to bring the messages that like if a UPS driver can do their seatbelt so many times a day, that every person shouldn't have the excuse that it takes up time. And people on flights kind of had that idea of seatbelts not just to prevent the injury, but it's to keep you in your seat so you can keep control of your vehicle. And I thought those were pretty good approaches. And we've reached out to our trauma surgeons. They came and gave pretty compelling testimonies at the legislation. Our main arguments we're going against, they're still just kind of a group of people that value freedom. So we have to kind of reframe our message I think we have to reframe our message to say that by wearing your seatbelt, you're kind of securing your own freedom there by not getting injured. So if we kind of try to reframe it that way, maybe that will be something we can look at in the next 2 years. So.
Do you have the support of law enforcement?
Yeah, law enforcement's very supportive. I think so. A lot of the past legislative sessions, it's been kind of going through as a law enforcement tool. This past year, we tried to reframe it as public health message. So a lot of the opposition thinks it's just a money grab, that we're trying to get more money for the police. Really, our ticket for this upcoming legislation was only $20, so it wasn't very hardly covered the cost of even pulling someone over. So we're trying to look at it not from a money perspective and not from a law enforcement control area, though they are very supportive of this. But we've been trying to reframe it more as a public health issue and just trying to save lives. So it's been discouraging hearing some of the legislators talk and say that they value their freedom over like 24 lives or something that would be saved by legislation. So discouraging, but we'll continue the work and try to come up with more strategies over the next 2 years, because we only have legislative sessions every other year. So a little bit of a window that we know we have to keep do the work now to prepare for 2 years from now.
To build the momentum.
Yep.
Okay. Anyone else want to share, either in the room or on Zoom?
I'll go ahead and jump in if you're ready. This is Vinny. So let's see, main things we're doing, and I'll kind of go work into this other stuff. We are, well, I think I mentioned what we do. Violent death reporting system. We have a domestic abuse death review team. We're working on falls. We have a lot of violence prevention work. We do both RPE, obviously, and we have some healthcare and violence against women funding. Our suicide prevention work is very, very limited because we don't have a source of funds. So we get like $50,000 to support a youth line, which is really sad and woeful. We do the unintentional kind of motor vehicle, pedestrian safety, and child maltreatment work happens in other divisions, and we partner with them. They take the lead. And I will say TBI is an area that we have some strength in. Probably the most excited I've been is just the ability we've had with our falls prevention work to not only expand the availability of classes across the state, but we're working with our state's hospital association and QI initiative to be able to integrate a screening and for falls risks, referral to evidence-based classes, kind of a seamless process that will begin to sustain, and we're working with our insurers to try to get some payment for those classes. I would say another area we've been doing some good work in is with our traumatic brain injury program. We've been fortunate in Iowa. I think we've had TBI implementation funds for quite a while. And so with the funding we do get for our advisory council, they can do prevention. So we've been adopting the Colorado REAP program work, doing some good work in sports concussion. And that's going really well. I would say another thing that's kind of interesting or exciting maybe is that with the federal CDC Disability and Health Grant, we've been trying to, and that's out of our office, coordinate that with our nutrition and health promotion folks to expand the training of people that can lead classes for people with disabilities. So for example, we trained 2 of our folks on adapting the falls prevention work for people with disabilities, but we're also partnering in some other chronic disease prevention. So we try to tie in that kind of safe streets with, you know, activity and injury prevention and falls prevention. What else? I would say, let's talk about challenges. One of them, which is kind of a weird good and bad. So I'm in the same division with our substance abuse programs, and we work very closely with substance abuse prevention on our violence prevention work and underage drinking. But they have all the funding for the PDO work. They've been dealing with all the naloxone distribution, PDMP, all that, and we just haven't had the staff, the ability to kind of work with that. So work is happening in our state, but I really would like to find a better way to marry some of our injury prevention pieces with it. One of the things I'm trying to figure out is if we could get funding to pay to add PDO data into our VDRS optional module, but we don't have the staff to do that with just our VDS right now. So that's what I'm trying to work on. We potentially don't know what's going to happen with healthcare reform like everybody else, but if we lose the PHHS block grant, that will severely hamper our kind of infrastructure for injury prevention right now. We have, I'm trying to think what else here. We have some limit. We have some EPI support, but our injury EPI support comes through the block grant, the PHHS block grant, and we have to share him with our substance abuse folks. So, you know, we do what we can. We get our data indicators out, but I feel like we're really limited in what we can or should be doing with informational briefs and kind of public information work because of our limited staffing. I will just say that our challenges really overall with governmental policies, we've never been able to get a helmet law in the state. I think we had it for a brief time, but long ago. And given, I think we've worked to get children included in that, but given the current, should we say, sentiment in our legislature since this past session, they passed Stand Your Ground and they legalized fireworks, I don't see we're going to have a lot of hope for much happening in the next year or so. I'm trying to think. I guess that would be all I would say, and this might be a good time to maybe see if Lisa wants to throw in some more work, because you work a lot with our partners in children's injury prevention. Anything else you want to capitalize on what's happening in Iowa, strengths or challenges?
Sure. Sorry, I was just trying to find my
Yeah.
unmute button. No, I think, we have a really strong relationship, obviously, just being in the same state with the Iowa Department of Public Health, but I think it's things that potentially could translate to other state health departments. Just being an academic institution, I feel like we have resources and technical assistance that we could certainly offer up, but some of the areas that we've been successful in partnering, at least in our state and smaller region, would be our annual Child and Youth Injury Prevention Conference, which happens every September. And so we have partnered with our two children's hospitals in the state, as well as the Iowa Department of Public Health and our Safe Kids coalitions to offer up a yearly conference for providers. Now, we used to offer that regionally, and we still do. We sometimes don't have very many takers, just based on, people being prohibited to travel at certain times with lack of funding. But we tend to try to invite in national speakers, so at least our local practitioners can get a flavor for what's happening across the country. And I really like this model of the risk and protective factors, and integrating that maybe into some of our conferences as well. So we probably have some things to learn from the folks in Colorado. I'm trying to think other things that we tend to work on. At the University of Iowa, I think we have some good experience with policy work. And so as you were talking about, seatbelt legislation and helmet legislation and things like that, we've been successful in at least providing the scientific evidence of why some of these policies need to be put in place. And I know then we work and do policy briefs, and we have a nice new policy brief guide that we'd be willing to share within the region that can help provide some structure to some of the things that people are doing in the region. And then one of the other things that our center does, and I know this is kind of how we connect back with Benny as well, but we have, our center has expert research teams, and these expert research teams have a focus area. And so we have rural acute care, road traffic safety, interpersonal violence, global injury and violence, older adult falls, and injury and violence research methods as our focus areas. And we have researchers as well as practitioners engaged in each of these groups. So they tend to work as a team and then advance research, but also practice-based strategies and evidence-based programs. So that's something maybe as this region matures and we figure out what direction we want to go, it might be a way to connect people to our expert research teams. And I guess just maybe the last thing that I want to say, I mean, we do work a lot with the RPE program with Benny, as well as the violent death reporting system, and providing, evaluation services, as well as just technical assistance, data abstraction, those things. And I just want to make mention, because I think with the president's budget as it is proposed, academic institutions are kind of a focus of where they want to maybe pull some funding, but I really feel strongly that academic and state partnerships have a place in the injury world. And I think it's something that if we can through this region, coordinate and make that even stronger partnership, I think we can show value and impact in the work that we do together. And I think I'll just leave it there.
Yeah, and Lisa, I mean, this is Carol. I mean, having been the director of an injury center for many years, I mean, I am very sympathetic to that issue, and was just learning a little bit more about it yesterday. But also, from the standpoint of academia, and there are other academic institutions in the region that aren't fortunate enough to have the power of an injury center. All of us, at least in schools of public health where we train students, have students who are also looking for projects and opportunities to work with health department programs as well as others. So for those of you in states who might have, opportunities and maybe don't get, one of the CDC fellows, there are still opportunities to work with your academic institutions and find a student who frequently are free or at least cheap. So, and they need training. Some are better than others. Some need more supervision than others, but it's a win-win if you can make it work.
Absolutely. Thanks for mentioning that, Carol, because I think that's so key. And I think that's one of the ways we've been able to support some of the work for RPE with Binny is through practicum students, but also through children's hospitals and Safe Kids Coalitions and to public health departments. So yeah, thanks for making mention of that.
Well, I think the other aspect of what you mentioned is as the funding lines for NIH institutes are going way down, and probably will continue to go way down, senior researchers are going to be more inclined to look to partner with state government because their path of least resistance, NIH grants, that's drying up. So it's probably a better landscape for research policy partnerships.
So I think you know what Utah's been doing, but so there's a Society of Prevention Research, and my boss, Craig Whitley, has been really involved in that. And one of the things was that we were finding there were a lot of researchers looking for projects for evaluation, pilot projects. And what we've started doing, and this is very recent, like the last few months, we've started the Utah Society for Prevention Research. And so at the national level, you have, just like Lisa may attend something, researchers from around the nation that come together. So we reached out to the 9 institutions in Utah, some key researchers, and invited them to be a part of the group to help connect them to our community partners that are looking for evidence-based strategies that don't have the funding or are looking for ways to evaluate their programs that, again, don't have the funding or are looking for something to do. So we have 2 things going on. Things that like have the pilot, so a new program, whether it be Hope Squads or Sources of Strength or whatever, an institution like University of Utah or Utah Valley University, a researcher may say, gosh, I'm going to bring this and we're going to do a pilot in Price. And we're going to put all the research and time and effort to there. And the other thing we have is that we have connections with the program, like when you're talking about the students now. We have BYU and Weber State and Utah State University have their graduate program, and I'm trying to remember what it's in, but they actually will create an evaluation plan for, the students create an evaluation plan for the program, as well as help them to evaluate it afterwards, which has provided an invaluable service to our communities. So not at the state, but at the local level that want to implement those strategies or policies and evaluate to see if they're effective. So that's been a really important part.
And how much does that cost to the community?
So far, nothing. And so what we've used is some of our block grant funding and some of our discretionary funding. So from the Partnership for Success grant that is coming to a close for us as the startup funds to bring these people together. But quite honestly, a lot of it's the students or the agencies have the grants already, and they're trying to find appropriate control and experimental communities. And so they want people, and they're trying to find the right places. And Utah has been a history of being a part of these research projects, and so that's why it's been a really great connection between the two. But yeah, it hasn't cost communities anything so far.
And I don't know if you're all familiar with the Laura and John Arnold Foundation. They have so this is a huge foundation with tons of money, and they have a specific initiative to fund low-cost randomized trials using administrative data. So this seems like a perfect match. If you have a state agency that's partnering with an academic institution already, and then you can discuss with that researcher what administrative data sets you have available for them to mine. Then go after this Laura and John Arnold Foundation low-cost randomized trial funding. They literally can't get enough applicants. They have millions and millions of dollars to give out for this initiative, and they can't find enough applicants.
Where are they based?
They're based in Texas, actually.
But they fund across
But they have
the US.
staff in Colorado.
And they fund everywhere?
Yeah. They fund all across the country.
So I know we got a little bit off of Vinny's challenges. I don't know if we're addressing them or not. Vinny, did you want to ask any specific questions of the group to get help with?
No, not necessarily. I'll put them out there because I know we're going to talk about ways we'll probably, help each other. But there was one more thing I did want to throw in that we've been recently pulled into, and I would just, again, for future reference, would love to hear some other experiences of other states. Both Cedar Rapids and Polk County, two of our large areas, have been really struggling with issues of increased youth violence. And actually the IPRC through Cedar Rapids and us here through our local county have been pulled into steering committees working to address it. And what we've been offering has been look at it from a public health approach, which has been a great opportunity to reach out. But we're limited, and so we're just trying to introduce the whole community to the idea of what does it mean to a public health approach. So because we've never had funding to do youth violence, and I don't expect we'll ever get it, I would love, again, to just see what other people are doing. And again, I look to that shared risk and protective factor approach that Colorado's using is a piece of it, but that's just another emerging issue that I'm sure we'll be dealing with. So that's it.
Well, and I wonder, are there enough other people working on youth violence that would be a topic for a whole?
Yeah.
I'm seeing, in the room, I'm seeing lots of heads now.
No, okay.
We've also had a couple people join us. So we'll let them introduce themselves in just a second. But so it sounds like a discussion of youth violence might be pursued. Why don't you newcomers introduce yourselves? There's a camera here that broadcasts to the people you can see on the screen.
I'm Alicia Peterson, and I'm with the Third Department of Health, and I'm
So I'm Susan Heen. I'm the Director of Safe Community, Safe Schools from the Colorado Attorney General's Office. And I'm also the founder of Safe to Tell, which is a statewide prevention system and reporting tool for mainly youth, school violence. The number one thing we intervene with is suicide.
Great, welcome to both of you. So what we're doing now is different states are just talking about what they're working on and particularly posing challenges where they might want some help. And I think Utah wanted to go next, am I right?
Yeah, I don't know that I have a huge challenge, but it is something I work on. But a lot of what we focused on the last few years is our opioid overdose, specifically prescription drug overdose from the substance use prevention perspective, suicide prevention and underage drinking, and in our communities, the suicide, because we have pretty high risk or pretty high rates, and I'm sure that Teresa can go with that one as well. Again, I'm traditionally substance use prevention, so my funding stream is primarily the substance abuse prevention treatment work grant, and they're really focusing on doing things such as mental health first aid and question persuade for PPR. And one of my soapboxes, which is why I was really excited about this conference, is the shared risk factors and trying to get not just state level agencies, but also the local levels to see that there's shared risk factors and to go back a number of steps before having to do a QPR or having to do an intervention or with the law enforcement having just to do the CIT. But trying to get that buy-in to the science, to get the buy-in to using systems so it's not just everyone have a knee-jerk reaction, but actually use a coalition model, whether it be communities at care or the strategic prevention framework or collective impact. I mean, there's a number of different really effective ways, but people seem to just do, oh my gosh, we had a crisis, we had an overdose, we had a death, we had a drunk driving accident, we must do something now. And that's I feel like I'm still fighting against that at the local level because we're trying to sponsor that science, which is why we have the Utah Society for Prevention Research to try and get them to do that. But
it's not just you either, because even with public health, we have such a tough time getting them to see the locals, see their role in suicide prevention. They think that's the local mental health authorities. They don't want anything to do with it. They feel like they'd be stepping on toes, and so it's an issue even within public health. Which they should be embracing it.
There's a perceived competition between agencies like, oh, that's yours, I can't touch that, or this is mine, you can't do that. And I think from the Strategic Prevention Framework State Incentive Grant, so what we affectionately call the SPIFC grant, one of the best things came out of it was our relationship with, again, I work with the Department of Human Services and Teresa's from the Department of Health, which in Utah are two separate entities. And the locals even said, wow, we're really impressed with how you're actually talking to one another, because at that point we hadn't been talking to each other. And I'm glad that I'm here. I guess I feel like I'm the only one in the health department. But I think that's what we're trying to do. It's a language thing partly, because when I say risk factors, and that's kind of some of the things the health department has done with collective impact, when I look at risk factors, I'm looking at what Brian presented yesterday, which is 20 risk factors and then protective factors. And I can remember being at a meeting and someone saying, well, we're talking about risk factors. I'm like, well, what risk factors? And they go, well, child poverty. I'm like, okay, what else? And they go, injury. And I'm like, what? Like, I don't think we're talking the same language. And I even went to the ACI conference in Denver just a couple months ago. And I went to a meeting for injury and violence prevention. And I was surrounded by all these hospitals, but they were looking at something very different from what I was looking at for risk factors. And so for me, it's a barrier of sharing that, not only the shared risk factors, but language. And how do we get to something that's shared that way? That's my big thing.
Good. I'm hearing some crackling. Are you folks on Zoom able to hear okay? Still okay? Okay. So the challenge around suicide prevention, anyone want to offer up any assistance?
Well, when you mentioned that, this issue of focusing on something tragedy. So interestingly, over 20 years in Pennsylvania, when we were trying to scale up the communities with their initiative, we've gotten into about 150 communities across the state, every single county. And an interesting thing we noticed is that all of those CTC coalitions arose for one of two reasons. About 3/4 of maybe 85% of them started because the state offered a grant and some local organization, like the county health department or whoever, pursued a grant, and then they got funded, and then they went out and tried to round up people to form this coalition. But the other 15% formed organically because something terrible happened in the community, a school shooting or a drunk driving accident after graduation, or a heroin overdose or something like that. And there was a swell of concern. And fortunately, the state government had sort of laid the groundwork already and prepared local health departments, the county extension offices, et cetera. They knew about CTC, they knew about that model, and they had some sort of basic background training in it, so that when something like that happened and there was this stir of concern, they could go in and offer a way to sort of organize that energy. And we found that the coalitions that started organically from community concern actually had greater longevity. They were more likely to be sustained after the state money ran out. The community didn't think of it as a grant. They thought of it as a tool to organize their energy and concern and pursue some evidence-based strategies to do something about it.
So we have two communities right now, and mine is one of them. And so we've got Park City, that's not mine, but Park City had 2 overdoses of, what was it called, Teresa? Sorry. What was the synthetic drug that they got? Pink?
Pink, yeah.
Okay.
It's a U4700 or something.
Yeah. So 2 youth overdosed in Park City. And the owners of Stein Erickson Lodge actually emptied out $250,000 to start a coalition. And we're like, oh, that's fantastic. So that's an example of what you're talking
The
about.
Vail Resort CEO.
Yeah.
That's what it was.
Oh, is that who it is?
Yeah,
Like, I just was like, and then in our community, we've had a number of suicides, and the reaction when we keep talking about, hey, let's start doing a coalition so that we can hopefully prevent these things. The response we got from 2 people in our group was, coalitions take too much time. We can't do that. That's too long. We need to do something right now. We need to have therapy in the schools, and we need to have, and like, we're going, do you understand how expensive that is? Do you know that that's like, this
It
point,
won't happen again.
right, I'm like, that's not going to stop it. That may be giving you another tool, and I'm
Right.
not against any of those solutions, but that's not, again, I'm in the prevention mindset, trying to get steps back. So yeah, and I think that that's what we're hoping that we see, is having people gravitate towards, again, the science and the models rather than, hey, let's do a
Fix, knee-jerk.
well, let's do an assembly and have everyone feel warm and fuzzy about
Well,
each
and that's
kid.
so good news. I mean, I just,
Oh, I
have
know.
to say that part of what we have to do is we also, I mean, the Center for the Study of Prevention of Violence, and I heard your talk, I think, you, Dr. Brian.
Yeah.
Okay. Part of it we do know, I mean, I couldn't remember the last name, Baumgardner or something. You know, we do know that in the aftermath of a traumatic incident, if there's an increased risk for risky behavior for youth to, I mean, you know, they get to the attitude you only live once. We see kids mourn the death of 2 friends in a car accident by gathering and drinking. It's part of making sure that they're coping in a healthy way, but they really need to have that strategy. Like we talk about preparedness and planning, every young person at an age appropriate level should have a strategy of what they would do if they're faced with a certain situation. Who would be the adults in their lives? What would they do? Who they would connect with? But everything we know about preventing youth suicide. So we've been heavily, like I've been working with communities, one of the biggest hotspots in 50 years. And we look at how, I mean, people are reaching out and grabbing my arm and saying, help us make this stop. And yet you see no additional resources from any state organization. Federal is now wanting to provide some resources and go around. State is now working, but this is after 2005, they were number 2 in the nation. And now we're looking at the last 3 years. But after a assembly, 2 more killed themselves that were in that assembly the following week. So when we look at what in the years we talk about how we ask the media not to talk about suicide, how to do it in a healthy way, and yet kids don't rely on the media. The social norms have changed. They're sending the picture of the kid hanging from the goalpost because they just walked on school property, and it is reaching out to not one district, not in 4 different school districts. There's word that a young person has killed himself Sunday morning, and by 4 o'clock that day, 400 young people gather in front of the school to mourn the loss. And when faith-based, we're connected with faith-based and all the stakeholders. We're like, can you go out there? Because the school's saying, if we send school officials, it's turning it into a school event. And how do you let 400 young people gather and mourn without any adult? And when you get there, you find out we have 400 kids from 4 different schools. I mean, part of it, I think, for all of us is kind of sharing the concepts for communities that are working. With the Air Force, we talked a little bit about some of the work, but the Air Force is really heavy in that community and how they've been effective in kind of stopping the suicides and talking to Palo Alto and Fairfax and their work. But the other part of it is the people that actually know where the opportunities were missed are the coroners. So the coroner's office is the one that is responsible for the investigative process. Law enforcement policies are not consistent, especially pertaining over the last 5 to 8 years. They've really changed in their role in responding to a suicidal individual. So we've been working to change those policies. I was just going to think about the study for preventing school shootings. We know that 4 out of 5, and that study ended in 2000, but 4 out of 5, somebody knew. The person that knew was a young person. With the coroner's offices that we're working with, we're calculating that it is more than that when a child completes suicide. That more than 81% of the time, it's more like 90% of the time, somebody else knew and didn't speak up so that an adult can leave. And that makes it different in what our frontline approach has to be. It has to be beyond looking at the signs, and it has to be the social media aspect.
And you and I chatted briefly as we were taking, but Utah has taken which is the Youth Safe UT, and that's been really helpful in a lot of communities. And I've seen it be effective. But I like some of the things you said, you know, the different mediums of reaching the population. You know, we already have Kim reaching out to media and sharing, like, this is the proper way to speak of it, and then
all the time.
Yeah, over and over and over again. Like things that just came to mind about them.
Oh, and I know what you and I talked about, but it really is, like you might have just heard in the media over the last few days, we were talking to Kim, that there was a case where there was a prevented planned school. And the intel that came in was a girl that was confessed suicidal. And it was after the treatment and through the parents searching through the diary that found the planning process. So the public doesn't really know that, but it is really important to say that we really try to lower the threshold of it's about your safety or the safety of others. That's the threshold where we want young people to reach out and engage an adult, because that's where there needs to be an adult guidance. They don't have to vet it, decide if it's real. We want them to use, you know, go to adults, keep telling. But if you need a way, because the only way you want to speak up is a way to be protected and anonymous because you're so afraid of social exclusion or isolation, then we just provide that resource. But that resource is just part of the pie. The other part has to be, how do we work with crisis response teams? Because we have to change our mindset on what crisis response teams do in the aftermath of a car accident, a shooting, the death of a teacher. We've got to really empower young people to have their own voice, I think, because they really have turned into our front lines at a much younger age.
And we also need to tap into that opportunity to promote at the same time. So it's not an either or. It's not an either, well, let's talk about something that's going to be effective 10 years from now, or we address this thing right now. We need to do both. We need to say, okay, you know, we're going to do what we can to address what's going on right now. But if we don't get upstream, I mean, you know, I talked yesterday about the fact that social isolation, that's beginning in kindergarten and first grade with kids that are exhibiting antisocial behavior towards their peers. And we can identify them, and we have proven effective programs that effectively teach emotional self-regulation in kindergarten and first grade. But that's not the place that people's mind immediately goes, you know. So
the upstream approach is really important. We try to tackle it. And Force and Strength is a great program. But, you know, we go into it with the high school and start an area, but we really need to get to the impacts, you know, those left behind too. I mean, there's the siblings, the younger kids, they're all connected through sports. But no, I totally agree in the upstream approach, and from a young age, teaching kids those safety skills or
school climate too.
Yeah, and the home visiting nurse program, like that, doubling it. I want to say though that we also track live daily in these areas the number of interventions they're doing. So where there's no increased capacity is when there has been one, the communication and the discussion that occurs, we start seeing additional reports coming in of kids in crisis and putting that out. So when you're seeing 251 interventions in a month of that's just one category. So suicide, drugs, bullying, cutting, depression. I mean, so just the one thing where this is an actual suicidal kid. There's no increased capacity. There's no increased counselors to even deal with the crisis that they are in. And if that was a pandemic flu outbreak, if that was a school shooting, where do we needed to also change our minds of saying how in our preparedness level we have pockets of funding to increase support in those communities that doesn't take years to get.
I'm going to cut you off because I'm aware of the time and just want to see where people want to go. But I mean, it does sound like yet another topic where there may be interest in having continuing conversation. I hate to cut off good discussion, but at some point we're going to run out of time, and I want all the states to have a chance to bring up what they want to bring up. So, and just Georgie and I conferred by passing notes back and forth that we can juggle the agenda a bit to shrink some of the later stuff to facilitate this conversation continuing, but not indefinitely. So who else would like to bring up issues? We may not have quite as long to talk about them, but I think it'd be good if everyone who has an issue they want to bring up at least gets it on the table and maybe puts it on the agenda for the next time around. So who else? We haven't heard from Colorado, Missouri, North Dakota.
Hi, this is Jeannie in Nebraska. Can you hear me okay?
Yes.
Okay. I agree with and I like the idea of partnering with your universities. We've started doing that in just a really small way with our journalism department. And, you know, we didn't really have much of a presence when it came to motor vehicle messaging or campaigns and things like that. So with working with our highway safety office, we're able to kind of hire an intern from the journalism college to help us with Facebook posts, Twitter posts. Those get shared with all of our Drive Smart Nebraska partners, and they pass those around. So we get a pretty good wide spread of that messaging across the state. And plus, as I'm getting older, I'm finding that out that messaging with younger kids is different than what I would expect to do. So it's a really good insight on having students of that age participate in public health. It's really fun to see that. The other thing is that we partner with the Brain Biology and Behavior Research Center at the university, and that obviously they're focusing on traumatic brain injury towards sports, but it'd be interesting actually to look at some motor vehicle issues through that as well. And speaking of policy, once again, we had to defeat, and we did defeat the motorcycle helmet repeal. We have an all-rider helmet law here. Thank God that's the only law that we have that's worth a darn. Everything else that we have here is secondary. So this year what we did, we kind of planned ahead because we knew this was going to come up, and our division created what was called Public Health Strategies for Motor Vehicle Safety. And what we did was we put our Nebraska data, and then we wrote what would be best public health strategy. So through wording it that way, we were able to include primary seat belts are good public health strategies, raising your law to age 8 for children to be in booster seats. And then we also focused on just general information about motorcycle safety, seatbelt safety, distracted driving. And so our partners use those sheets to educate our legislators on what is best practice and how it could benefit Nebraska, because having our motorcycle helmet law has benefited us so much financially, and especially now with the budget cuts, I think that helped to really push that issue, because they're cutting money from all kinds of programs. So why would we want to add to the budget costs with removing our motorcycle helmet law? I think the only thing that with staffing is always kind of an issue. And so we've been involved with the Children's Safety Network coin. So that has really helped us address motor vehicle safety more effectively, as well as the child abuse and neglect. Although we don't have staff that focus specifically on child abuse and neglect, at least through the coin, we're able to kind of start getting our feet underneath ourselves. So that would be kind of one area that we could benefit from learning more about. Thank you.
Okay, good. And Jeannie, I was just going to mention, I know one person at the University of Nebraska who is an injury epidemiologist. If you haven't connected with her, she may be able to help you connect to some students and other resources. Her name is Lorena Baccaglini.
Oh, great. Thank you.
In the Department of Epidemiology. And if you send an email, I can send you back her contact information. She was a former student of mine a number of years ago and is on the faculty there.
Great.
Jeannie,
thank you.
You mentioned being involved in the coin and having some interest in child abuse and neglect prevention. Could you elaborate on that a little bit more? Like, what would that look like for you in terms of a learning opportunity? There are different levels of kind of child abuse and neglect prevention, so I'm just interested to hear a little bit more about that.
Yeah, well, through the coin, they offer up certain evidence-based strategies for you to choose from. And so what our group chose was to work through our home visiting program. and work with home visitors on educating those high-risk families about, pretty much we focus more so on shaken baby syndrome and in the development of like the education of that and the crying plan. And so the coin has helped facilitate that along the way a little bit more through their evaluators and their content experts. So, but like I said, we're still trying to get our feet up underneath ourselves because we don't have a person that's specifically in our injury department that works on that. So something new that we're learning.
Great, thank you.
Any other thoughts about that challenge before we move on? Okay, so help me thank everyone. There's still several states that haven't had a chance to talk about what they're working on, what their challenges are. Shall we spend a few more minutes on that before we move to sort of the future planning stuff? I just want to make sure that everybody's happy with how we manage the agenda. Okay, so who wants to go next?
Hi, this is
Here
Mandy
was
from
shaking
North
their heads
Dakota.
yes, and I didn't hear anyone on Zoom screaming out saying no. So sorry, it's hard to do this with multimedia.
Hi, this is Mandy from North Dakota.
Mm-hmm.
I'll just talk a little bit about some things that I'm excited about, although we're working on many, many things. We recently launched in March, in collaboration with the Minnesota Poison Control System, an online poison prevention training program to train healthcare professionals, the community, just a variety of people, daycare providers, EMS, physicians, nurses, that type of thing, and that's going really well. And then we also were fortunate enough to join the Injury Coin with the Children's Safety Network that Jeannie was talking about. We're focusing on teen driver safety, which thankfully for us aligns with our MCH priorities in North Dakota. Let's see, we applied for a zero suicide grant, so fingers crossed that we get that. And then some challenges that we have. Data is always an issue for us. We have trouble getting access to data. We just recently received hospital discharge data and had been working on that since the 90s. And we always have issues with epi work. We don't have a lot of epis in North Dakota, so the injury program has to borrow, bag, and steal from the chronic disease and MCH division to get any epi work. And we have applied for PHAPs. Unfortunately, other people like the cancer division and some of the other divisions in the same section have also applied for a PHAP. So unfortunately, the injury division has never received the PHAP, although we have applied. We applied to the CSTE to get an epi that way and have not gotten it. So I'd say that's one of our biggest challenges is the not having an epi and access to data. Also, we this last session tried to strengthen our graduated driver's license, and it was defeated. So if anybody has any suggestions about what we could do for the next session go around, that won't be until 2019.
Mindy, could you, what was how were you trying to strengthen it? What failed? For the
I'm sorry, if somebody
a driver's license law, sorry.
I'm sorry, whoever asked the question, I didn't quite hear what they said.
Hi, Mandy. This is Lindsay from Colorado. I was just curious that the attempt to strengthen the graduated driver's license law failed. I was just curious in what ways you were trying to strengthen it. I'm not familiar with your law.
Oh, okay. Well, right now, as I look at it, we don't really have a graduated driver's license, but the only reason it's considered a graduated driver's license because it's listed in there in the law that that the number of passengers can't exceed seatbelts in the car, so it's not really truly a passenger restriction. But that's how it got in. So to me, it's not truly a GDL, but it's able to be called that because of it says number of passengers for the number of seatbelts in the car. So we tried to limit the number of passengers. Currently, our GDL only in North Dakota, kids can get their license at 14 and a half. I know, scary. But our GDL only goes from when they're 14 and a half and then ends when they turn 16. So we were trying to get the GDL to go until they were 18.
Yeah.
And then changed the age of the driver from, I can't remember what it was before. I think it might have been 18, and we were trying to change it to 21. And so a lot of the rural legislators had a huge problem with that because they, it's too much time commitment, they were saying, for the parents to have to go with their kids to sports and stuff. And there were some teens from local high schools that actually testified in favor of it and said, you know, that my safety is important and I'm glad that my parents value it. And one of our legislators actually said, don't trade your freedom for safety.
Oh, to a child?
So, quick question.
And Mandy, don't feel bad because that's the same mantra here in Wyoming. Yeah, I know we're one and the same, DL, because it's we're, you know, very conservative state. So.
And so, in terms of your, I guess I'm gonna have to go back and look at. What is the rate of teen death currently in North Dakota?
I guess I don't have that information right in front of me, but I could get it.
Okay. Because yeah, this sounds like similar to what we're doing with in terms of PO and some of those things, in terms of building the hotspot maps, in terms of influencing legislators. So one of the ways that some states have been successful is really getting buy-in from legislators by showing infographics around teen driver deaths in their particular communities, and so that they become the sponsors of your public health initiative. And so we can definitely look. I know Karen has just sent out the injury reports, but we can definitely look at some of those and maybe be able to help you with that kind of technical assistance if you want to give me an email shout later on.
Okay, great. Thank you.
Mandy, this is Lindsay again. I was just curious if, in part of your preparation to work on this year, do you have a child fatality review program or child death review in North Dakota?
Yes, we do have a child fatality review, and it's housed in our Department of Human Services. It's the Child and Family Services Division, and I do sit on the child fatality review.
Do they review teen or motor vehicle deaths?
Mm-hmm.
Because I know in Colorado, before we had a real graduated driver's license law, it was the same thing. The first thing that passed was, okay, have the number of kids in seatbelts that there are a number of seatbelts. So it was very similar, but what was the turnaround for us was really looking at the child fatality data and the number of kids who were dying in the cars. So, because there were so many kids in the car, our rates were going up in crazy ways. And so we were able to convince the legislature at that time that, by just restricting the passengers, it's going to prevent all these deaths because you can see it really clearly through our data. And so I just was curious if that was true in North Dakota for your child fatality review data as well. Because the National Center for Child Death Review, if you don't have kind of epidemiologists for child fatality review, which we didn't at the time either, may be able to provide some technical assistance to pull that information from the National Center system if you guys contribute to that.
Okay, thanks, Lindsay. I appreciate that input. That's great.
Any other input on this particular issue?
I know that we have a graduated license, but we also actually allow, if there's 10 people in the car and there's 8 seatbelts, but 2 other people can still be in the car. We just talked about that. So we have that law. You're allowed to have more people in the car than seatbelts. But we do have a graduated license.
Well, and there's also, I know when I lived in North Carolina, one of the issues was kids in the back of pickup trucks. And,
oh yeah, we can't do that.
But I think some states still allow it. Okay, yeah, other states, which Missouri?
Well, Missouri, I'm in the injury prevention program, so it's kind of hard. I do work with COIN. We do suicide, child passenger safety, and interpersonal violence. So that's going to help us out a little bit, get a little bit of funding for suicide, which mental health lost total funding. So we've been trying to provide them with signs of suicide kits to give out to the schools. That we work with the regional support centers to get those out, because a House bill was passed 1853 that will require each school, I think by next year, to have a suicide prevention program in place. So we're trying to get all those schools certified or figure out what programs they're going to use. So right now we've been using signs of suicide. So I'm not sure if there's another program out there that we should be using. I'm not sure, but we provide those kits to the school, so it's at no cost to them whatsoever. So that's good. And then I work with State Kids Coalitions a lot. That's one of my main jobs. So right now I'm just trying to figure out how to strengthen our injury prevention program. We work with, Department of Mental Health and transportation. So I'm just trying to figure out how to collaborate with everybody and get them involved. So kind of struggling.
So any guidance to help her? Do you work at all with the injury group at WashU?
Yes.
Yeah.
We do.
Yeah, because they may have students who
Right.
give you some extra muscle.
You said suicide, child passenger safety, and so on.
Interpersonal violence.
Interpersonal violence.
So do you feel that what you need mostly is person power or ideas or
okay. It just seems like I'm floating out there. I don't know which way.
Can I just ask a question about passing the piece of legislation that made suicide prevention program? How did that happen?
That's a great question.
It's pretty awesome.
They just tagged it onto the bullying. We had a bullying. I should have brought the House bill actually. They just tagged it onto that. So we have a bullying thing that's out there too that you need to. Like it needs to be reported or whatever, so they just tagged the suicide prevention onto it as well. So yeah. And if you want a copy of that, I can send it out to you guys too.
So how can we help her?
Well, I think there's I've heard a lot of kind of suicide prevention today, and so I think there are opportunities for us to develop some sort of. Sorry, I have a Jolly Rancher in my mouth now, of course. I think there are lots of opportunities for us to talk about, what some evidence-based programs, best practices that folks are using in the region, etc. I mean, I'm not the suicide prevention person here. I know very limited information about it, but I think that there's an opportunity for states to share and for that to be a potential learning opportunity in the near future.
I would also, I guess for this whole region, capacity seems to be a huge issue. And so I would hope that, I know that we're going to do the PHAP, but maybe as a part of our larger strategy to really focus in on being very aggressive about, even the partnering with the academic units is a really viable mechanism by which you can increase your labor force. I was a postdoc and I was a graduate student, so we're cheap, and we have
and smart,
and we work really hard. So it's usually a really easy way, but we just having a mechanism, because I think when you're a person of one, it is hard to then get these applications together. And so maybe being able to provide templates and samples would be something that would be helpful, because I really would like our region to increase the capacity. Lindsay's team is massive in comparison to many of yours, but she's been really successful, I think, at gathering some of these different funding sources and starting from small and kind of building over the years. And so we want to kind of get this region, our region compared to the East Coast, they also have much bigger teams. And so we want to, my goal as the project officer is to really work on the capacity building and the technical assistance for your subject areas, but you can't do the work if you're just one person having to do everything. So I do recognize that's a limitation. So that's kind of where I was trying to pull resources and really help with that piece initially. And just a plug, I know some of you didn't apply for the DDPI FOA, but those states, we're getting ready to write the next one. And so I think I sent emails out to everyone. But again, as we get ready for the next round of funding in the next 2 years, this region really could do with that kind of capacity building FOA. We funded every single person in the data-driven prevention. So it was for for those who didn't get the bigger grant for PFS. The lower grant, the smaller grant of $300,000 is still more than what we get for core. So that's what I tell people, like, I love core, but we give $250, and for DDPI we gave $300,000 at starting, and so it's really, I'm going to strongly encourage those of you who did not apply to really, we're going to work to get you to apply this time. It really is meant for those of you who have a small capacity to be able to hire an FE. Jeremy's group has done great work with the funds that we've given them, and we've been super pleased with them as a DDPI state. They're like one of our model states going forward, what you can do with that kind of funds to build capacity.
I'd like to hear more about that.
Yeah, and are there ever opportunities for states to partner and go for one of those, or is it state
health department? Yeah, it is strictly.
But two can't team up.
No, not two. No, because this is one of those bipartisan funding announcements. So there's enough money for each state to get their own.
Yeah. Okay.
And we gave a minimum of $300,000, which is more than what we give for all of core.
When did that come out, and when will it?
It will. So we're finished. We have 2 more years, but so we're starting the writing, and so we're pulling success stories right now and things like that. But then for those states, this is for so Utah and Colorado, you got the bigger grant, and so this is for those states who didn't qualify for the bigger grant because they don't have the
PFS is coming to an end. No, for Utah. Isn't it? And we're talking a different language. What's PFS stand
Prevention
for?
for states?
Oh
no.
I'm thinking Partnership for Success. Am I correct?
I was gonna say, as a matter of fact, as all of you who are PDO grantees, as I have been warning, more funding will be coming. So you need to be writing your stuff.
The other thing I was going to suggest, so one of the things for staff that I know the health department and our office have been successful at doing is that when you said you didn't know how it came to be that suicide prevention, we were given in the bill that was passed, they put the fiscal note attached to it for a position, and it was not a one-time only position, it was ongoing funding. And one of the ways it was promoted is that not only is it a public health issue, but also decreases other outcomes, shared risk factors, and decreases the size of government is how it was built. So, but that's something that, well, because if you think about it, prevention really, and what my favorite slide that Brian showed yesterday was when one of the agencies, it was criminal justice, saw $85 million savings. That's what prevention does. And so what we had come through the health department, the State Board of Education, Department of Human Services, all were a part of drafting that bill, or we're at least not, we're involved. I shouldn't say, I don't know how strong everyone's role was, but we were involved. And then we were asked to put, is there a fiscal note? So I don't know who in your agency might be a part of that, but that's something to consider as well for staff.
Colleen, were you going to say something?
Oh, yeah, I don't know if it was.
We often have
but Jamie alluded to that, in Colorado, we've been successful in getting grant funding from CDC, and we kind of have some like common like methods on how we apply, and a lot of that has come from just like Lindsay's grant writing expertise in probably like OCD behavior on how she not in a bad way, like and we've learned, but like just the way to kind of look at funding opportunities and walk through them and really consider really understand what an objective reviewer would be looking for in scoring them, and my role in that has been around the evaluation piece and really coming up with kind of a standard template for our branch on how to respond to specifically CDC funding and applying to that grant application that really walks through the CDC framework for evaluation. And so I'm happy to share those. I know last year, one of our epidemiologists I was like maxed out in my ability to help with grant writing on an evaluation. She just took what I did and applied for our alcohol EP grant and was successful, and said that that tool was really helpful. So that's like one component that we may be able to help as a region, sharing those resources. And
I would strongly encourage that. They are being on several we have to, as required, do objective reviews in other centers, and so I actually have recused myself from the Colorado for their reviews, because they have it's a formula that it always hits all the points. And so their logic models are hugely, hugely successful in terms of when we're looking at objective reviews. We've seen applications even from within their agency, and it seems like they all have that same kind of template that seems to score really high. And because you have to remember, our objective reviews are built from people from outside of our center, and so, but we all use the evaluation framework as the CDC, and so. And some of those same kinds of tips, though, I think would translate even to other agencies for their grants. So I think that would be
I mean, maybe it would be a future topic for a meeting, and I would be happy to share my OCD ways.
I don't know if that was the highest one.
It's very successful. Then I was going to say something similar in terms of, CST. We've had a CST fellow in mental health, one of the behavioral health ones, which I know typically has fewer applicants for than some of the other areas for CSTE fellows. Happy to share our application for that. We didn't apply for this round. Our fellow just ended.
Was that MA?
No, that was preventive health. That was
public health prevention.
Oh, right. Thank you. And they don't have that one, unfortunately, which is the one I really liked, but PHAP is probably good too.
I'm biased too.
I'm biased because that's how we got called.
I will say though, I mean, like, and I don't know about PHAP. Do you know if those fellows sit on objective review panels? Because like when I was a public health prevention service fellow, that was one of our requirements, and that's actually how I learned a lot how reviewers look at the application from the other side, and was able to apply that skill in applying for funding.
This last year, I was one of the people who we have now pulled PHAPs into doing objective reviews.
I mean, because I think that's a really good thing to like to then apply to then their work as a PF fellow and at the site too.
Yeah, we have pulled PHAPs into doing that, but we also have there's other fellowships. There's informatics fellowships that we offer at the CDC that are available. So there's a ton of other fellows that you can get in your office. But the CSTE is, for those of you who need EPIs, or that's of course an excellent technical group of people that we highly sought after, but we highly recommend that you can get.
And I would just say, like, thinking of, when I came on board to the state health department 10 years ago, we had a much smaller branch. I think there was maybe 7 of us. And so, I mean, still bigger than a lot of states, I realize, but, that was pulled from some, different areas and where the structure was. What I think we took advantage of is, no matter if it was a topic like prescription drug that you might not currently be working in, seeing it as an opportunity to build capacity and going after it anyway. And so, and then one grant ends and you get into whatever the next thing that comes along, whether it be state money or foundation funding or however you piece it together. But looking at that to say, okay, I'm going to build some core competencies of staff and make people versatile. And even though your grant is for prescription drugs, say on the epi side, taking the opportunity to do some cross education so that people are ready to move on to that next topic and where that next funding comes from. And I would guess Utah has been,
super successful.
Yeah, really successful in the same ways of being, taking the funding where you can get it, but getting more out of it than just the topic area that you're addressing. And I think that's really important too.
So it sounds like yet another topic for a future discussion. So this part of the agenda on planning for the future, we're actually doing as we go, in thinking about strategies to get everybody in the region funded. I mean, wouldn't that be a wonderful goal for us to have over the next 5 years, to get everyone funded in some way or another to enhance their injury efforts? Did we provide you some initial help to get going? The only state I think that hasn't spoken up yet, am I right, is Colorado? Has everyone else had a chance?
We've been talking a lot.
Is there anything, Lindsay, you want to bring up? I want to be sure we save a little bit of time for the other agenda items. I mean, we've been passing notes and deciding to shrink them, but we should spend a few minutes. But do you want to talk a little bit?
Yes. I would say, and George and Colleen, and I know Dwayne's on the phone, and you guys chime in too. We have kind of a big crew since we're in Colorado, but I think we are really obviously big into the shared risk culture factor thing, and are trying to work on that. So that's what we're excited about. We've grown as a group and have a large group of people, and so I think our challenge is how to align our work in a way that makes sense but doesn't start to duplicate where everyone's going to every meeting, and those types of things is one of our challenges. And then really turning our attention to evaluation. We have been working in this way and growing along the way as we did it in terms of size of our health department team, but we've also been, I think, really working on pulling together the partnerships, working more with local communities. So much of injury and violence prevention work happens in local settings. And, I think because the injury funding is rarely big enough to grant money to local communities, you can do it in small, chunks. I think we're trying to be creative in the technical assistance we provide to local communities to say, how can we help you be successful at the local level with local level funding sources or other types of ideas to figure out how we can create that at the local level. And I think that's really our challenge. And then how do we evaluate some of these efforts that I think are just newer in the way of looking at things. And we have a real opportunity in our state, and because of the marijuana funding and other things that help make this conference happen, I feel like we have a unique responsibility too to help contribute to the field and to use, these resources might not be around forever. So while we've got them, really put them to good use. In terms of topics, I think the area where we are now struggling the most is older adult falls. We had previous funding from CDC as well as the ACL grant for falls, and we've been struggling about what the state health department's role is if the state health department doesn't want to be the one training in older adult falls and doing the trainings. And I know a lot of states approach it that way. It hasn't been feasible for us to create that level of infrastructure, and so we're trying to figure out how can we work with our hospital partners? How can we work with other funding mechanisms within our state through emergency medical services and trauma and grants that they have, and then support our partners in really having them be the applicant. So falls work is happening, but maybe not as directly through the health department. So I think that's some of in terms of a topic, probably the one that we're currently, not working in as much as we would like. I'll stop there because.
So maybe that's a topic that others could help think about.
Yeah, and I'm particular. I mean, I know a lot of states like Jeremy and Vinny and Iowa, et cetera, lots of you are doing really great falls prevention work and haven't, maybe now have the ACL grants that are helping support that work. But some people have been doing it without any of those resources. And we've tried to get a piece of our preventive health block grant money to do that, and it never seems to win out at the department level with how we're going to use that funding. And so I'd be curious about ideas from other states that have found ways to do it that we could learn from. I would appreciate that.
Can you clarify again? It's not my thing, but so is it the issue the funding to pay for and do the older adult falls, or is it because you said you didn't know if it was your responsibility? So that's why I was not sure.
I don't know. I think we should be working on older adult falls. Okay. I think how it has looked through the ACL funding is a lot of, it's classroom group-based exercise classes at 10 to 15 participants at a time. And so I worry about the reach, and is that really the best use of our time? We took a train the trainer model, and with the funding we had from CDC to build infrastructure through hospitals, and we're really intentional on saying we are both not going to be the trainer or pay you to do the training, so that we built some sustainability there, and that work is continuing. So we do have some falls work happening, but I think we as a state health department should be doing something else, but I'm not quite sure what that is. I don't think sending staff to do these classes is really feasible for us. And some of our local public health agencies really don't have injury and violence prevention infrastructure except for very few in very few situations. And so, they're not really engaged on the issue either. Where
they're more youth, I would say more child and youth focused because of communities that care and child fatality prevention.
What are their shared going back to what are there shared risk factors that you could show and highlight and see if they're focused on youth and the CTC model, that this is something that would be advantageous to that community because of the shared risk factor for adult. And I don't know.
That's actually what we're waiting for.
Okay.
Some shared risk factors around unintentional injury and how we can then team that up with intentional. So so that's one of the things that we're waiting for. Not that we don't know what some of the risk factors are for falls, but we're hoping that it will be more robust. And
where we've looked at it is with suicide, so crossovers with social isolation, folks who are socially isolated, particularly older adults, are at higher risk for suicide, and also not the people who are going to show up to a class that's going to help build their strength. So we've done some thinking. We haven't really found some funding or momentum to really try anything in a robust way. But yeah, I think looking at that concept, and there's overlaps with prescription drug, of course. There's there's other ways to kind of look at it, but I think just even the suicide discussion today is so youth focused, and I really believe that you've got to do suicide prevention, for example, from the all age groups, because
well, in our 65 and older population, I don't know how it looks in Colorado and other places, but it is really
exactly right.
So it's binge drinking,
I think that
same age group.
that also makes me think that's something that we, as a department, or as a division, and where our branch is located, is really thinking about healthy aging, and so it's more than just falls as a topic area, suicide, prescription drug, substance use. It's chronic disease too. It's more than just ignorant and violence. So thinking about how healthy aging hits all of it.
And what's public health role versus direct services, which obviously there's a huge need for direct services and systems of care and all of those types of things. But I think there's what's more the primary prevention role, and where the intervention points are kind of what we're.
So are there states, whether in the region or out of the region, that are doing a really terrific job on older adult fall prevention?
I think there's a lot of states that are doing really great work with the evidence-based programs. I think Utah is doing a great job. New York's doing a great job. Oregon, like in terms of the programmatic stuff, I am not aware of a state that's kind of taken it to sort of a broader systems level approach, other than studying and incorporating that into healthcare systems and things like that, which has had various.
I would say that falls is unique in that it's difficult because you have that aging as well. And, one of the things we were hoping for with the last core grant is that we'd be able to pick up some of our falls stuff in there because, we lost our grant and there's such a need for it, but, we couldn't do that. Yeah, I'm not blurring at you, but it's been problematic because we have to find, we just lost our falls person. So,
well, we did too.
We may or may not. I don't even know how we can keep that up. And
that's right. So my brain, as I'm thinking of shared risk factors, and you talked about isolation and suicide, but that's also where you have the connection. So at a local level, again, this all does relate back to funding. But for a direct service strategy, might be something that you do have the grand families, or you do have something that's connecting, getting transportation for older adults from their home to the senior center or to a nursery. And I do say nursery, not a nursery facility where they're doing the preschool. And you see the positive, there's research connected to that. So that's where I'm saying those shared risk factors. And then again, I keep hoping, this is my thing, that if we tell them all the wonderful research and connect them to the possible funding streams that they'll apply and want to do it at a local level, that's my hope. But
and I think also maybe partnering with some of the housing authorities.
Right.
HUD gives grants for this sort of thing, and has told me in the past we don't get enough good grants. So they have money that
Yeah,
they
I think
want
that's
to
a great
give
example
for,
that we could explore.
you know, for housing, home improvement kinds of stuff. And
We can have stuff for within, for transportation with the local mental health facilities. They often have grants that provide transportation to get their clients or residents in the community to different places without having to come in for treatment. So it isn't always just treatment that they're providing services for transportation.
Yeah, but how prevalent is that off of the Wasatch Front? Because
I'm like, I'm thinking of Weaver Human Services,
Yeah,
so I'm like, I
yeah.
know that they're always driving people around, but
because that's one of the things that you've
Yeah.
seen with aging is that it's starting to raise our domestic violence rate as well, because they get to the point where there's no support. You know, they're just very isolated, often live in rural areas, and their solution is murder suicide. They do a suicide pact, and so it's really raising our DV rates as well.
And I don't know.
I don't either.
Some of that, like, is topic specific. We might have shared this perspective, but it's even like when we talk about suicide, it's not going to be one thing fits all. I mean, when it's young, it's got to be age appropriate. And for me, whether it's elderly, you have to involve the stakeholders at the local level, both for-profit, nonprofit. I mean, there's these organizations, and even walking around, people are like, can you come and talk to our group for a minute? But seeing, like, even just the networking opportunities, for me, like, that's something that's such a gap, is just pulling regions together to have the conversation. So when I think of the elderly, you've got to say in every community, they're going to be nonprofits, medical, for-profits, and maybe there could be more of a collaborative effort that could be guided by the health department.
Somewhat. I mean, some of our communities are so extremely rural that really there just aren't those agencies. There's no nonprofit, you know, there isn't that agency to partner with.
Well, that's true.
I mean, that's rare, but you know, there are those.
But there are fire
there
departments.
But
There are fire departments. There are Rotary clubs and things like that. I mean, so.
But I would say, you know, I'm thinking of San Juan County, that has a population of 115,000, and it's the largest geographic county that we have, like size-wise, the smallest population, and you have people that don't have adequate housing, that are living on the reservation areas, that don't have phones. I mean, they don't have phones, and they walk, and they don't have cars, so they walk.
Right.
But the isolation is, that's a big factor. So,
can I mention one last thing for Colorado before we probably should get wrapping up? So please has a
And
moment
move on
to talk
to the
about
next.
evaluation. The last thing.
This is DL.
Hi, DL.
Can you hear me?
Yes.
Yeah. One thing that we're starting to explore here in Wyoming, for more kind of a systems approach. I'm in a prevention and health promotion unit, so we have integrated cancer, tobacco cessation, chronic disease, substance abuse, and suicide prevention, is how can we collaborate together and work with our Medicaid group, who has the total health record, which is an electronic medical record and eventually will turn into also a health information exchange. How can we come together and create a short questionnaire that doctors can administer to their patients to hit on falls prevention, to hit on chronic disease and medication, to talk about cancer services and what's available, to talk about tobacco cessation and addressing suicide, and also how to be safe drivers, especially for our older adult population. So that way the doctors have one questionnaire they can go through with all of their patients, and then make referrals out to, oh, contact this program, or go to your community, or do this, do this, do this. And so we're in the beginning stages of developing that.
Great.
So that sounds like something you could at some point share and be part of the conversation. Georgie, did you want to make some comments?
The last thing I wanted to say in terms of Colorado and challenges that we're facing, I mean, I see it kind of both a challenge and an opportunity, is around child abuse and neglect prevention. Obviously, we are the recipients of the Essentials for Childhood grant, but one of the conversations that we've been in recently, and some people have mentioned child maltreatment prevention activities, etc., is that now we're talking about sustainability. How do we sustain child abuse and neglect prevention efforts in the state of Colorado, considering we did have this opportunity and it isn't traditionally viewed as a public health issue? So we have, you know, that's been a challenge in determining what that looks like moving forward. But I think there are also some successes and some opportunities that have come from that 4-year story, and that is what collaboration looks like with the traditional partners that have worked on that do work on child abuse and neglect, and what collective impact looks like at a statewide, like for a statewide initiative at the systems level. So I think that's also an opportunity. And we are also, as the RNCO state, we are also the National Peer Learning Group for Child Abuse and Neglect. So I hope that all of you will participate in that as well. And there will be a lot of opportunities to learn more about what's happening both at the individual level, direct services, and what the opportunities are at the community and societal level for what is public health's role in child abuse and neglect prevention moving forward. So I'm really excited to talk about that. Can I make a plug for Safe States then? now?
Yes. Yeah, so let's move on and talk just briefly about next steps and then go to the evaluation.
So just in terms of the Plains to Peaks Regional Network, we will be starting some recurring meetings on a monthly basis. I just want to guide everybody back to the, this is something we talked about in our first opportunity to meet when we discussed the needs assessment. We've developed a blog or a website for the Plains to Peaks Regional Network that is plains2peaksnetwork.com, www.plains2peaksnetwork.com. And you can find on there a calendar that will be updated with events, both learning opportunities for the Plains to Peak Regional Network, as well as opportunities that you will all share with us. We just started, so the tabs are there. It's not very full at the moment, but it will be. And then there's an opportunity for priority focus areas based on the national peer learning work. So the focus areas are systems thinking, hosted by North Carolina, child abuse and neglect, hosted by us, motor vehicle.
Washington?
No, they're TBI.
Massachusetts and Maryland.
Yeah, sorry. TBI is Washington, and then there's motor vehicle and sexual assault. And as we get kind of updated information, everybody's kind of in the very preliminary stages of organizing. The National Peer Learning Work will update you all with information, and you're all invited to participate in any one of those opportunities as you see fit. And finally, the last thing I wanted to say was that the Safe States Conference in September 7th through 9th?
I think it's
the next week,
12th through 14th, great, thank you. September 12th through 14th will be an opportunity for all the national peer learning groups around those 5 topic areas to kick off. So we look forward, we hope that a lot of you will be there, and we look forward to having conversations at that point in time. Am I missing anything, Sarah?
Yeah. And we may be reaching out to some of you too for like more one-on-one conversations or via email, just to learn a little more about what are you doing on child abuse, what would you like to be doing, like just to help us think about what direction this should go. So look for that.
Yeah.
And then are we also holding a Plains to Peak Regional Network meeting
at Safe States as well? So there will be an opportunity for us all to meet again, and hopefully more of you will be able to participate in person at the Safe States Conference for us to have another conversation.
But if not, we can still do Zoom.
Yeah, and we will.
It's in Denver.
It's in Denver.
Right?
Yeah.
So
it's in Denver.
Same week as the National Prevention.
Yeah. Where's it?
Anaheim. Sorry, I'm going.
But if someone from your state.
Well, we hope a lot of you will be able to participate, and if not, we will have this interactive opportunity via Zoom for you all to participate virtually. So,
and some of you may be interested as well in the SAVOR conference, which is coming up, Society for Advancement of Violence and Injury Research, September 18th to 20th in Ann Arbor. So that is also September 18th to 20th in Ann Arbor, Michigan, hosted by the Michigan Injury Center. So that, I think, Georgie kind of gets us started on thinking about next steps, and we've gotten a bunch of ideas from this meeting, and maybe, as we summarize what came out of this meeting, that can help start building agendas for
absolutely. I've been making a list of everything that people have been talking about, from partnering collaboration to a potential for Jamie to talk to us a little bit more about PHAP, other opportunities for recruiting folks to kind of build on infrastructure, sustaining falls prevention work, what that looks like. That seemed to be a pretty hot topic. A lot of suicide talk. So what is it, what are the best practices? What is some programming that folks are using in our region that could potentially be helpful for Missouri with their new legislation? Potential for research policy partnerships, youth violence, youth suicide prevention, child abuse and neglect learning opportunities, accessing data, how to leverage other opportunities when you don't have access to EPIs or data, what that looks like. Policy opportunities is another exciting one. Hotspot mapping, teen driving, sexual violence prevention, all the programming that's kind of using hotspot mapping as a tool. I know in Colorado we're using some of it, so I'm excited to talk about that. DDPI opportunities, and sharing grant writing success stories.
Yeah, and then the other one I heard is working with your academic partners, and we want to have some discussion about best ways to approach that.
Yes.
I was just going to say, is there, just a little bit off, but is CDC going to be doing the Child Maltreatment Center for Childhood FOA again, or is that
the Centers for Childhood FOAs within the Division of Violence Prevention, and I don't know.
I can tell you based on our reverse site visit that nobody knows.
Nobody knows.
So I don't think
no one's counting on it.
Yeah, nobody's counting on it. Yeah, we had conversations about sustainability, but sustainability in terms of how the state itself can sustain the work moving forward, not how CDC could sustain the funding moving forward, really. So, but there's, we have great partners across the state. There are 5 Essentials for Childhood grantees that are doing very different things that I'm happy to, to kind of group together and potentially have a learning opportunity for them to all share what they've been doing. It's really
I think also, Teresa, you'd said that you're not funded.
And all the unfunded states,
I would be curious to hear how you're sustaining that in your state without the original CDC funding.
Essentials for Childhood is amazing in that there are more unfunded states participating in the program than funded, and your experiences are priceless, really.
And honestly,
literally priceless.
Literally priceless. Again, it's the partnership between health and human services.
Yeah.
So our division of Child and Family Services who are spearheading the effort.
Yeah, and that's exactly how it's looked in Colorado. It's looked different in different states, so I think that there are learning opportunities from the different states and the way that they've approached it. But I think that partnership is critical and to move any sort of prevention effort forward.
Great. Okay. Well, let's segue to evaluation.
Yep.
Elise,
I just want to thank you for making time for this discussion. This conversation has clearly been very invaluable and fruitful, and all of the themes that Georgie mentioned, I also took notes and caught those too, and I think that those can inform the evaluation. Awesome. But I just, Colleen and I really wanted to formally ask the question of, you as the members of the network and the end users, and as important stakeholders in this evaluation, how are you defining success of the network? So what does that look like to you? What do you hope to see in the future?
One thing I heard, maybe came up in the discussion, was just that everyone is funded in the next 5 years. And I don't know if, I guess it doesn't matter the funding source necessarily, but maybe it's funded, or maybe has like a fellow or support, because we talked a lot about fellows too. So.
Capacity.
Yeah. However we define, so something around capacity and how we have to figure out how to measure and define
collaboration, all those things that would strengthen infrastructure.
I would say collaboration. What agencies are, again, I really do feel like the odd man out right now. Everyone seems to be all about the health departments, and that's why I'm like, I have no idea what core is. No idea what core is. And when you're using these languages, that's why I was like PFS. But increased collaboration between agencies and states. I think I love learning from other people and utilizing networks like this. Where we can measure that.
And maybe add tribal.
Yes, for sure.
Oh my gosh. I think maybe this is an opportunity to give a plug to the entire network that's here in person and on Zoom. We encourage participation from all different sorts of partners. This is not a public health and academia specific partnership. Mm-hmm. If you have human services folks who are interested in partnering, or other state agency or nonprofit folks who are interested in learning more about these opportunities and how to strengthen their programming. We encourage you to invite them. This is not an exclusive opportunity by any means.
Well, but so invite them. What I'm saying, I think it's really important when you're talking about DCFS, getting them to the table because, like I said, we have this barrier of language. And I looked at, I just went to your website and I'm looking at the shared risk and protect factors, and it's a completely different language for me, by the way. And I used risk and protect factor models. But that's the kind of thing that I would see is like getting people from the Division of Child Family Services here, getting people from juvenile justice here, because again, we all have this similar goal of having a healthier community, but we have different measures, even within our own agencies, and different ways we reach it. So when I refer to collaboration, I'd love to see an increase not only with the tribes and other nations, but with our own, peer, having.
And just so you know, like even within our branch, that's like how we define risk and protective factors varies depending on your focus area. And so that's like a big push for us to like really create that common language.
Can I ask just a question of clarification? When you say collaboration, like, do you mean like someone who is from your maybe discipline in another state, or do you mean?
Yes and yeah. I mean, so she's not. So we're in two different agencies.
Right.
I consider this collaboration with my peer because we're both having the same outcome that we want to see. But I also do want to see an increased collaboration where I can talk to someone.
With that express. Okay, that's helpful.
And so I think a measure might be, how often do I, Utah, reach out and interact with someone from Colorado and actually gain information or utilize that information. Like the same thing that we do with the slips for this conference, when they're like, is this something you're going to take back and use? I've checked yes, and quite a few of them. So that's something that I consider a success and an outcome. It's building my capacity and awareness of what I can do.
So can I throw in along that line, one thing I was thinking of is if we could quantify or measure changes in state programs' capacities, kind of based on the core competencies that Safe States has adopted. And I don't know if there's any information that we could glean from the most recent State of the States, but to me that would be a measure of a benefit of the regional network. So if that makes sense, that was one of the things I was thinking.
So Vinny said using the Safe States core competencies as a potential measure for measuring capacity, like what those competencies are.
Improvements,
and
yeah.
We have we have data available, the Safe States data states, which is, well, I don't know, the Safe States do that regionally or by state or?
By state. We do it by state.
So, but that's something that we had talked about in our the potential data source to track that over time as well.
I bet that would help.
Yeah. And just a footnote on that, I'm part of a group that's working with the other RNCO, the one out of North Carolina, the name of which I can't remember, but because they've changed it. But they're going to be doing a series of webinars to build capacity on the core competencies. And in our discussion, I mean, I wonder, I mean, how many of you are even aware and familiar with the core competencies? So there may be, there may be some awareness building. I don't want to put anyone on the spot, but that's an opportunity that's coming up that we will all be able to participate in.
Is that the core competencies for Safe States or the public health? I guess it'd probably be good.
It's the injury prevention core competencies.
Okay, so
that Safe States and SABRE did.
Okay, I just want to make sure because I know that term.
In
our field,
exactly. I'm sure core competencies for Susanna are very different.
So I think agreeing on like making sure that those injury and violence prevention core competencies are the ones that we want to measure for this group, and I would guess that then that would apply, for multiple disciplines as well.
The only other thing I was going to say measuring would be, and you talked a bit about policy or not just funding, but things that I love that the CDC is very supportive. I love that SAMHSA is very supportive of this, but sometimes having that local or state-based funding, so seeing maybe in a number of years how many of us have improved by having a primary seatbelt law or that graduated license, or having a state-based funding for a position for an epidemiologist, because somebody was talking about they don't have an epi. I don't know who said that, but a couple of them did. But those are the things that I think could also be measures that either, and even Utah, we could say that, what have we improved as far as policy. So
I would like some sort of, I don't want to say I would like some sort of evaluation, but I would like some way of assessing and improving our injury community groups, our implementation groups, because, and I don't know how everybody else feels about this, but we have such a tough time keeping people motivated on that, keeping people participating, reviewing the plan. There's just so, and it's because it's honestly because we have these focus areas, and to have this big all-encompassing global injury group in Utah, they look at it and they're just like, we're just not interested in talking about suicide. I'm a falls person, or and so we when we first started the whole big community planning board, we had really good participation, and now it's less than what we have here that we can get to participate.
I think that would also be a good topic of future discussion.
Yeah, that's true.
Evaluation
Yeah,
and discussion,
yeah.
Because we certainly struggle with the same thing, and frankly, we don't do it in the same way anymore. And so there's groups that care about these topic areas, and there's leadership within that group, and then kind of through our staff and our partners that, kind of get the broader, bigger picture, having them really serve as the people we talk to about, hey, does this strategic plan jive with what we should be doing? And then, bring the topic specific groups together, because I think
that's kind of what we've ended up doing too.
Yeah. And then you have to spin it for your CDC report.
Yeah.
Tell James.
Yeah.
Implementation
No notes.
groups.
Because there's already so many other groups that we have.
Before, not this, but the last one before that, we just did separate injury groups for each topic. Yeah. And then they wouldn't let us do that anymore, so we brought everybody together in a board, and now we're going back to that separate
meeting
groups.
a couple weeks ago.
No, we had it in January. I think it was last one. We only have it twice a year.
Okay. And that's what we.
Yeah.
So I think you can still do what that sounds like the spoke model, where everyone has a work group, and then you just have that one representative come back as the representative for that work group.
That's exactly what we have now. And they're not coming. Like the falls people aren't coming.
They don't care about sexual violence.
Yeah. Yeah. Just because of the way we have the priorities, and they just don't want to.
I know this is, but going off that, I think that it's because everyone's got so much going on.
Absolutely.
I mean, I know in your office, and I know that we all have different things, but your office this week, you've got all different people in different conferences. Yep. Same with my office. Yep. And so your battery's about to die on this, by the way.
Thank you. Very low. Very low.
It's gonna die
I can plug it in while we're almost.
plug it in. But that's, I think, part of the issue is that how do we maintain that engagement without just without diluting and without exhausting everyone, so that we're going to a violence and injury meeting, we're going to the state suicide prevention meeting that has the shared risk factors,